We're going to switch gears now and spend some time discussing the eye and vision. The eye is a complex sensory organ that provides a glimpse into the central nervous system. It is composed of many parts, each with its own function. The overall function of the eye is vision. Light enters the eye through the pupil and passes through the lens, where the beams are refracted onto the retina to form a crisp image. The image that is projected onto the retina is the inverse and reverse of the image seen. The ciliary muscle controls the shape of the lens, allowing it to adjust the angle of refraction. The fovea is the point on the retina with the highest visual acuity, because it contains about half of the fibers in the optic nerve. Now, slightly nasal to the fovea is the optic disc, which is where the optic nerve exits. It is also your blind spot, because there are no photoreceptors over the optic disc. The retina is composed of both rods and cones. Rods are more numerous, but have poor spatial and temporal resolution. They're important for black and white vision. Cones are highly represented in the fovea, and they provide for high visual acuity. Cones are for color vision. The pupil is the hole in the center of your eye that allows light to pass through. The iris is what gives you color in your eyes. The sclera is the white of your eyes. It's a tough connective tissue covering the eyeball. The extraocular muscles insert onto the sclera. The cornea is a transparent layer that protects the eye. In the anterior segment, the lens is bathed by a clear, watery fluid called the aqueous humor. Dysregulation of the production of aqueous humor leads to glaucoma. In the posterior segment, the fluid is called vitreous humor. Note that the posterior segment is different from the posterior chamber. The posterior chamber is a small area behind the iris and in front of the lens. The choroid is a thin tissue layer containing blood vessels to the eye. It's sandwiched between the sclera and the retina. The USMLE does not test advanced questions on ophthalmologic pathology, but there are a few questions that you should know. Retinitis is infection of the retina. The most common cause is CMV retinitis in immunocompromised patients. Untreated, it leads to progressive vision loss and blindness. On ophthalmologic exam, you will see cotton wool exudates and retinal hemorrhages. Treatment is with antivirals foscarnet or ganciclovir. Iritis is infection of the iris and the anterior chamber. Symptoms include unilateral painful red eye, blurred vision, photophobia, and tearing. The diagnosis is made by slit lamp exam, showing flaring in the anterior chamber, which appears as a smoky haze. Treatment here is with corticosteroids. It's important to know that near vision is achieved by the ciliary muscle contracting, which relaxes the lens so it is more convex. Distant vision is achieved by the ciliary muscle relaxing, which contracts the lens so it flattens. With aging, the lenses become increasingly sclerosed, so they develop problems with near vision called presbyopia, and thus many elderly patients require bifocals. Also, glaucoma, macular degeneration, and cataracts develop in the elderly, which can also lead to vision loss. Retinal artery occlusion is caused by embolization of plaque material from the ipsilateral carotid or ophthalmic artery. Now, who's your typical patient? You'd have a middle-aged man with carotid artery disease who presents with sudden, painless, and complete loss of vision. The opto exam will reveal pallor of the optic disc and what's called boxcar segmentation of blood in the retinal veins. You may see a cherry red spot in the fovea because the retina is quite thin at that location. Aqueous humor is produced by the ciliary body. Try not to confuse this with the ciliary muscle, which controls the concavity of the lens. This occurs in the posterior chamber, and the humor then travels to the anterior chamber through the pupil. It's resorbed in the canal of Schlemm. Glaucoma is defined as increased intraocular pressure from aqueous humor within this system. Chronic open-angle glaucoma is caused by decreased flow through the canal. Acute closed-angle glaucoma is caused when the angle between the iris and the cornea suddenly blocks the flow. Chronic glaucoma is associated with gradual loss of peripheral vision, but it's painless and silent. Most people don't even know they have it until someone screens for it in a visual acuity exam. Now, acute glaucoma has sudden onset and is very painful. A sample question on the USMLE might say, a lady woke up with severe right eye pain, headache, decreased vision, and nausea. You measure the optic pressure and it's 70 millimeters of mercury. You should know that acute glaucoma is an ophthalmologic emergency. Cataracts. This is a disease that increases in prevalence with age. The lens, which is normally transparent, becomes opaque, and visual acuity is reduced, eventually leading to blindness. In the picture, note the complete opacification of the lens observed on slit lamp exam. The pathogenesis is thought to be due to progressive oxidative damage to the lens, causing scarring of the lens, and then healing by opacification. Risk factors for cataracts include age, smoking, alcohol, sunlight, and trauma. If you do see cataracts in children or young adults, you should suspect a congenital toxic metabolic cause like galactosemia or diabetes. Papilledema. This is a sign seen on ophtho exam of increased intracranial pressure. Essentially, when you look in, the optic disc margin is blurry. Increased intracranial pressure usually presents with headache, blurry vision, and a cranial nerve 6 palsy. But to establish the diagnosis, you must use fundoscopy. Papilledema is a sign that there is increased pressure in the brain, but does not establish the diagnosis. For instance, let's say a 26-year-old obese woman comes to you with headaches, nausea, vomiting, and visual changes. You look into her eyes and see this. What's the most likely diagnosis? So in this case, pseudotumor cerebri, which is usually seen in young, obese women. There are 6 muscles that move the eye around, and 3 cranial nerves innervating the muscles. Cranial nerve 3 innervates 4 of the 6 muscles, the superior, inferior, and medial recti muscles, and the inferior oblique. Cranial nerve 3 also controls pupillary constriction and the levator palpebrae muscle. Cranial nerve 4 only innervates the superior oblique muscle, and cranial nerve 6 only innervates the lateral rectus. Now, what would a deficit in cranial nerve 3 produce? This would give you the down and out eye because of unopposed actions of the superior oblique and lateral rectus muscles. Also, there would be ptosis due to loss of levator palpebrae innervation. Pupillary dilation and loss of accommodation due to loss of parasympathetic drive to the eye also occur. Now, what would cranial nerve 4 palsy produce? Well, here the eye would be elevated and extorted, so the head will be tilted toward the lesion and chin tucked in to compensate. This action brings down the affected eye to produce a more level field of vision. Now, how about a cranial nerve 6 palsy? In this case, you would get horizontal diplopia. How do you test for these muscles? One option is to have the patient's eyes follow your finger as you make an H. The inferior oblique is isolated when the eye is looking nasally and up. The superior oblique is isolated when looking nasally and down. The medial rectus is best tested when looking nasally, and lateral rectus best tested when looking temporally. The superior rectus is isolated when looking up, and the inferior rectus when looking down. Let's talk about pupillary control. There are 2 terms that are frequently confused. Constriction, also known as miosis, and then we have dilation, also known as mydriasis, D for dilation or mydriasis. Pupils constrict due to parasympathetic tone provided by cranial nerve 3 through the Edinger-Westphal nucleus. Pupils dilate due to sympathetic tone provided by the vagus through the T1 preganglionic nerve. This leads to the superior cervical ganglion, to a postganglionic sympathetic nerve, and eventually the long ciliary nerve. Here's another critical topic in neurology. Light enters the retina and exits via the optic nerve at the optic disc. The nasal portion of the retina, that is, the temporal part of the visual field, crosses to the opposite side at the optic chiasm. The temporal part of the retina, meaning the nasal part of the visual field, stays ipsilateral to the input of light. The nerve then continues as the optic tracks until they reach the lateral geniculate nucleus in the thalamus. From the thalamus, they travel to the visual cortex in the occipital lobe for processing of the image. There are two paths. The superior fibers project from the thalamus to the upper bank of the calcarine fissure via the parietal lobe. The inferior fibers project via the temporal lobe to the lower bank of the calcarine fissure. This path is also known as Meyer's loop. The pupillary light reflex is much faster than the visual processing. Light from the retina will reach the ipsilateral pretectal nucleus. Nerves originating from the pretectal nuclei will then synapse in the Edinger-Westphal nuclei, which are bilaterally innervated. The Edinger-Westphal nuclei affect the parasympathetic functions of cranial nerve 3, leading to pupillary constriction when light is shined. The pupillary light reflex is thus afferent through 2 and efferent through 3. The consensual response is due to the bilateral innervation of the EW nuclei. Now, a Marcus Gunn pupil is seen when the retina or the optic nerve is damaged, as in multiple sclerosis. Because there is decreased light input, the pupils do not constrict as much when light is shown into the infected eye. This is called the swinging flashlight test. When you shine a light into the non-affected eye, you produce a direct and consensual pupillary constriction. However, when immediately swinging the flashlight to the other affected eye, there is less light perceived and the pupils will actually dilate when the light is shown. As we've discussed, there are two major functions of cranial nerve 3, controlling most extraocular muscles and parasympathetic output. If you were to cut the nerve transversely, as pictured here, the parasympathetic output fibers compose the outer rim, and the output fibers to the ocular muscles are more embedded. Thus, the parasympathetic fibers are more affected by compression. Clinically, you'll see a blown pupil that won't constrict to light. Things that might cause this are baryaneurysms and increased intracranial pressure. On the other hand, extraocular muscle output is most affected by metabolic and ischemic causes, such as diabetes or hypertension, because of decreased diffusion of nutrients to the interior. Retinal detachment is a separation of the light-sensitive membrane in the back of the eye, the retina, from its supporting layers. It can occur without any clear cause, but is also associated with trauma to the eye, prior eye surgery, and diabetes. The retinal blood vessels can bleed and cloud the vitreous fluid. Patients often present with bright flashes of light in the peripheral vision, blurry vision, or blindness in part of or all of the visual field.